Hi, this is Dr. Reynaldo ROJoson, Director of ROJoson PEP TALK. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP TALK. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My PEP talk today is entitled Fundamentals and Generalities in Medical Management of Goiter, Part 2. This is part of the health disorder course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of Goiter, Part 2. Part 1 consists of the following topics, which was taken up before. What is a goiter? What are the common types of goiter? What are the causes of goiter? And how common are the goiters? For Part 2, the topics will be clinical diagnosis of goiter and paraclinical diagnostic procedures for goiter. Part 3, there's another part in the series, treatment for goiters, health restoration, and maintenance after treatment for goiters. Definition of terms in the title and delimitation of coverage of talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities, general statements of information, not covering specifics and details. And medical management to mean diagnosis and treatment, usually done by physicians. The clinical diagnosis means a conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are what are felt and observed by the patient or a person on the body, whereas signs are findings of a physician after physical examination of a patient. The procedures in the clinical diagnosis of goiter, usually it starts with a patient presenting with symptoms. Then the physician evaluates the symptoms to look for cues for a goiter and then cues or pattern for a particular goiter disease. Thereafter, the physician does a physical examination to look for sign cues for a goiter and cues or pattern for a particular goiter disease. In the end, the physician processes the symptoms and data to determine 1, whether a goiter is present, and 2, if present, what is the goiter disease. The processes used in the clinical diagnosis of goiter, pattern recognition, and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Whereas a prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Common symptoms that will lead to suspected presence of a goiter: lumps or lumps on the front, base, and central neck, part of the neck, which moves up and down with the swallowing, lump or lumps on the side of the neck, palpitation, sudden weight loss, and persistent fatigue. Persistent fatigue is a cue or alert signal for hypothyroidism. Palpitation and sudden weight loss are cues or alert signals for hyperthyroidism. Lump or lumps in the front, base, and central part of the neck, which moves up and down with swallowing, and lump or lumps on the side of the neck are cues or alert signals for tumors, which could be benign or malignant, but this needs more sign cues for it to come out with a more specific diagnosis. The ROJoson way of evaluation, after a patient tells me her and his symptoms, which may suggest a goiter, examine right away the neck and check the pulse rate. I additionally gather other data as indicated with the goal of more specific and accurate clinical diagnosis. After examining the neck and checking the pulse rate and gathering other indicated data, I have these possible situations. Scenario 1, or first situation, thyroid gland is not palpable, thyroid gland is not enlarged, there are no nodules on the thyroid gland, there are no neck nodes, pulse rate is less than 90 per minute, which is normal, no symptom cues for hyperthyroidism and hypothyroidism. So the clinical diagnosis here should be a normal thyroid. Another situation, thyroid gland is palpable, it's enlarged, there are no nodules in the thyroid gland. The clinical diagnosis is goiter, but which has to be evaluated further for a more specific diagnosis. There is a goiter, and the pulse rate is less than 90 per minute. The clinical diagnosis is a non-toxic goiter. There is a goiter. If the pulse rate is 90 and above, then the clinical diagnosis is a toxic goiter. There is a goiter. It's diffusely enlarged. The pulse rate is more than 90 per minute. And there are tremors. And then there are bulging eyes. Okay, so the clinical diagnosis is toxic goiter, hyperthyroidism in the absence of bulging eyes, but in the presence of bulging eyes, then the diagnosis is a Graves' disease. It's a particular type of hyperthyroidism. There is a goiter. It is diffusely enlarged. The pulse rate is less than 90 per minute. There is persistent fatigue. The clinical diagnosis is a non-toxic goiter. More specific is hypothyroidism. Goiter, diffusely enlarged, pulse rate less than 90 per minute. There is adequate intake of iodine-rich foods. There's no history of persistent fatigue. Clinical diagnosis is non-toxic goiter, and more specific, diffuse colloid adenomatous goiter. There is a goiter, diffusely enlarged, pulse rate less than 90 per minute. There is history of inadequate intake of iodine-rich foods. Clinical diagnosis, non-toxic goiter, more specific, iodine deficiency goiter. There is goiter. There are nodules. The pulse rate is less than 90 per minute. The clinical diagnosis is non-toxic goiter, but which has to be evaluated further for more specific diagnosis, specifically whether cancer is present or not. There is a goiter. There are nodules. Pulse rate is less than 90 per minute. There are positive cues for malignancy like hard nodules, fixed nodules, hoarseness of voice, neck nodes, and or distant mass. So clinical diagnosis is non-toxic goiter, more specific, thyroid cancer, but which has to be evaluated further for a more specific type of cancer. Goiter, nodule, pulse rate is less than 90 per minute. There are hard nodules, fixed nodules, hoarseness of voice, and neck nodes, which are positive cues for malignancy. So the clinical diagnosis is non-toxic goiter, more specific, thyroid cancer, and more specific, the type of thyroid cancer present is papillary cancer. There is a goiter. There are nodules. The pulse rate is less than 90 per minute. There is a distant mass suspicious for metastasis, which is a cue for malignancy. Clinical diagnosis is non-toxic goiter, more specific, thyroid cancer, and more specific, follicular cancer, another type of thyroid cancer. There is a goiter. The thyroid has nodule or nodules. Pulse rate is less than 90 per minute. There are no cues for malignancies. So the clinical diagnosis is non-toxic goiter. And more specific, it's a benign colloid adenomatous goiter. I have been using the ROJoson way of evaluation for more than 40 years now. My batting average is more than 95% accuracy in my clinical diagnosis. The 5% error, or less than 5% error, I corrected right away with paraclinical diagnostic procedure to make it 100% accuracy in the end. Let's now go to paraclinical diagnostic procedures for goiters. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain of the primary clinical diagnosis and you need to be certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes. First, the degree of certainty on the primary clinical diagnosis, and second, comparison of the treatment plans for the primary and secondary clinical diagnosis. As a rule, if there is no need for a paraclinical diagnostic procedure, if you are quite certain of your primary clinical diagnosis, and two, if the treatment plans for the primary and secondary diagnosis are the same. If there is a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, risk, R stands for risk, C stands for cost, and A, availability. The physician gives or lists the various options of the paraclinical diagnostic procedures in the first column and then gives data on the BRCA. With the data given, the patient is asked what he or she prefers. Example of a BRCA comparative analysis of paraclinical diagnostic procedures. First column, options 1, 2, 3. Second column, benefit. Okay, the goal is to be more definite on the diagnosis. Then the data are accuracy for option 1 is 99%, accuracy for option 2, 90%, accuracy for option 3 is only 60%. Assuming that the risks are all acceptable, the cost, 4,000 for option 1, 3,000 for option 2, 1,000 for option 3, assuming that they are all available. If given such data, the choice here will be option 1 because it has the highest accuracy. If the patient cannot afford 4,000, then you can go for option 2. But the least recommended option here is option 3 because it has the lowest at 60%, which is not acceptable. The common paraclinical diagnostic procedures that can be used after the clinical diagnosis of goiter are the following: thyroid function tests, imaging procedures, and needle aspiration with or without biopsy. There are competencies that are required of the physician managing goiters in terms of the use of paraclinical diagnostic procedures. Number 1, know the uses and indications of all known instrumental and laboratory diagnostic procedures for goiter, use as needed and as indicated, select the most cost-effective one, and know how to interpret the results. Thyroid function tests, some examples, FT3, FT4, TSH, are used to check the levels of thyroid hormones in the blood. So one can end up with a euthyroid, meaning normal values, hyperthyroid, oversecretions of the thyroid hormones, and hypothyroid, undersecretions of the thyroid hormones. Indications for the thyroid function test: 1, when not sure whether a patient has hyperthyroid or hypothyroid. Number 2, when needed to have a baseline and follow-up values to monitor the subsequent medical treatment. Interpretations for thyroid function tests: if you have normal FT4 and normal TSH values, then euthyroidism. elevated FT4 and below normal TSH, hyperparathyroidism, below normal FT4 and elevated TSH, hypothyroidism. The imaging procedures. The indications will be when needed to evaluate the structure, which can be done for ultrasound, CT scan, and MRI. And at times, you also want to evaluate the function of the thyroid gland, in which case thyroid scan and PET scan can be used. So if there are multiple options for the imaging procedures, then choose the most cost-effective ones. Indications: ultrasound, CT scan, and MRI can be used to evaluate the structure, meaning the size of the thyroid gland and whether a nodule present is benign or malignant. Thyroid scan using radioactive isotope is used primarily to determine whether there is a nodule that is hyperfunctioning or not. In this picture, it shows a hot nodule or hyperfunctioning thyroid nodule. So this is a information which can be gotten from a thyroid scan. Needle aspiration with or without biopsy. Indications: when needed to determine whether a nodule is solid or cystic. Cystic means it contains fluid. If cystic, the needle aspiration, once all the fluids are aspirated out, it may be therapeutic in outcome. Number 2 indication will be when needed to get a sample of the solid nodule for biopsy, whether benign or malignant. And at times, the specific disease can be revealed through the needle biopsy. So this glass slide shows the sample of tissues gotten to be submitted to the pathologist for microscopic examination, or what we call biopsy. Here just shows you how a needle aspiration is being done. Simple needle inserted into the mass with the patient sitting down. Can be done in the clinic. Then the physician aspirate. And you can see some of the fluid coming out. So this turned out to be a colloid cyst. And after all the fluid has been removed or aspirated, the mass can completely disappear, or it can be reduced in size, in which case the needle aspiration is now both diagnostic as well as therapeutic. Again, let me repeat, competencies required of physicians managing goiters in terms of paraclinical diagnostic procedure. Okay. Know the uses and indications of all known instrumental and laboratory diagnostic procedure for goiter. Use as needed and indicated. Select the most cost-effective one. Know how to interpret the results. There are several issues to discuss in the use of paraclinical diagnostic procedure for goiter. There are a lot of confusion, not to say errors happening. Issues are listed down here. Ordering tests not needed for diagnosis of goiter. Shotgun approach. Ordering every possible test just to catch a specific diagnosis of cancer. Inaccurate results, not knowing how to interpret. Using the fad or popular ones without comparative analysis. In terms of benefit, risk, cost, availability of other options, and usually with no considerations for cost effectiveness and patient preference. Examples of a practice being done by physicians: ordering thyroid function test and thyroid ultrasound in one go, in one package for all patients with goiter. This is an example of a shotgun approach. Okay. And so patients with nodules with no symptoms of hyperthyroidism and hypothyroidism do not need to have thyroid function tests. So these are rampant practices which are not recommended. The results of paraclinical diagnostic procedures are not always 100% accurate. There are percentages of errors and non-conclusive results which must be recognized by the physician-clinician. The physician-clinicians must know how to interpret and evaluate the results and correlate them with their clinical diagnosis and decide or make a decision whether to accept, whether to hold, or whether to repeat. A lot of times, physician-clinicians accept the results as finals. So this is a rampant practice which has to be remedied for the patient's sake. Using the FAD, the popular one without comparative analysis of the benefit, risk, cost, availability, and of other options, usually with no considerations of cost effectiveness and patient preference. So example here, accuracy 99% for option 1, 90% for option 2, 60% for option 3. So looking at all the data, the best option here is option 1. Another example, more specific now, 3 imaging procedures, which are all indirect examination compared to biopsy, which is a direct exam. Okay, so just comparing the 3 indirect examinations, you have 2+ for ultrasound, 1+ for thyroid scan, and 3+ for CT scan. Risk, no pain for ultrasound. For thyroid scan, there's no pain, but there's radiation. For CT scan, there's no pain, but there's radiation. And in terms of cost, you have CT scan having the most expensive price. So if you were to choose which one's the most cost-effective one here, one would go for ultrasound. Another comparison, this time adding biopsy, which is another paraclinical diagnostic procedure. So compared to the other 3, it has the most direct way of getting into getting the information. Okay, so direct information can be gotten. So that's why it has a 4+ diagnostic yield. So the risk here is that there's a little pain, and then the costs are placed here. So if you were to choose the most cost-effective one here, unless the patient does not want any pain, then biopsy is the most cost-effective one. Summary takeaway in this part 2 of the PEP talk. I have discussed the clinical diagnosis of goiter and also the paraclinical diagnostic procedures for goiter. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on the fundamentals and generalities and medical management of goiter. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, at kapangyarihan to gain greater control over decisions in the medical management of goiter. With that, I end my PEP talk. Fundamentals and Generalities in Medical Management of Goiter Part 2. I hope I have empowered you, the lay people, to have an understanding, better understanding of the fundamentals and generalities in the medical management of goiter. Thank you and good day. Mabuhay kayong lahat.